So one emphasis of the talk was not only to emphasize the utility of the drug in second-line setting, which should be by now very well known, but to say that the benefit of the drug, it's much greater than what the clinical study projects. We also showed the data that improves the iron levels. Iron levels are hallmark of polycythemia vera. They go very low because iron is basically food for red blood cells, and everybody is iron deficient and may have some symptoms. On ruxolitinib, it appears that everybody is improving and normalizing iron levels without iron being given to a patient. We don't really know how it is possible, but it happens. We also now have a long-term evidence that the drug works very long time. After 4 years of follow-up of every patient on the studies, 3/4 of the patients who respond are still responding. So the durability of the benefit is much longer than in myelofibrosis. In myelofibrosis, usually is about 3 years. That was the first indication for ruxolitinib. It appears to be much, much longer. And then we also showed that the thromboembolic events, this is the ultimate goal of the therapy, to decrease the blood cell count, and that would decrease the thromboembolic events, appears in the safety analysis to be much, much lower than in control arm. And some new data that has not been published yet, but presented at different meetings over the last year, show that when you compare these findings from the clinical study to historical matched patients from different registries, that actually there is significant decrease in thrombosis and possibly also effect on overall survival in the second-line setting.